Welcome to Kern County Public Health's Winter Respiratory Illness Symposium. My name is Bryn Kerrigan. I'm the director for Kern County Public Health. It's wonderful to see so many dedicated professionals gathered here today, united by a common goal: to enhance our understanding and management of respiratory illnesses that often peak during our winter months. As we know, winter brings unique challenges. The cold weather can exacerbate respiratory conditions, and seasonal illnesses like influenza and RSV present significant risks, particularly to our vulnerable community. Today, we will explore effective strategies for prevention and treatment. Our lineup of expert speakers is eager to provide valuable insights and practical tools that you can implement in your practice. Tonight, we will discuss our local winter respiratory illness data and surveillance, community risk factors, immunizations, outpatient treatment, and how to prevent hospitalization. Please use tonight as an opportunity not only to learn, but to connect with one another. Collaboration and communication are vital in our efforts to provide the best care possible. Your commitment to your patients and Kern County is what makes a difference, and it is truly inspiring to be among you all this evening. Thank you for being here, and thank you for your dedication to improving respiratory health here in Kern County. Together, let's equip ourselves with knowledge and strategies that will empower us to make a positive impact on Kern County residents this winter season. I hope you all enjoy tonight's event. And now, without further ado, I am pleased to introduce Paul Rusidlo, a health superhero of Kern County. As the Assistant Division Director of Health Services at Kern County Public Health, Paul has been fighting the good fight in public health for over a decade. Paul is armed with a Master of Public Health and Epidemiology from the University of South Florida. Before he donned his epidemiologist cape, Paul was busy inspecting kitchens and training staff, transforming eateries into safe havens for food lovers. More recently, as a senior public health epidemiologist, Paul became the go-to guru for all things data-driven, wielding numbers like a wizard casts spells. His passion for data has made him a respected leader, helping Kern County make informed, health-conscious decisions. With Paul on the team, Kern County is in good hands. Please join me in warmly welcoming Paul Rusidlo.
All right, good evening, everybody. Like Bryn said, my name is Paul, and today we're going to be talking about our local data that we see for COVID, RSV, and influenza, as well as where you can find updated data, both at the state level and locally. And we're going to talk about our population demographics as they pertain to risk factors for severe disease. So by the end of this, I hope you understand the sources of surveillance data and can describe where we get them from. You can interpret local respiratory virus data, apply demographic data to your patient population, and navigate available data products and dashboards. So first, we're going to start with the sources of our surveillance data. So CDPH is one of our biggest sources for surveillance data. They get data from clinical sentinel laboratories and their respiratory laboratory network. These laboratories report the number of lab-confirmed influenza and other respiratory virus detections and isolations on a weekly basis to CDPH. We also have syndromic data from the Sentinel Provider Program, which is a partnership between clinicians, local health departments, and the California Department of Public Health with CDC to conduct surveillance for influenza-like illness. Admission data from Kaiser, so it's California Department of Public Health, gets data from Kaiser on their admissions for RSV and influenza. Historically, it was only for Northern California, but beginning this year, they'll have Southern California data as well. And then death certificates and wastewater. And locally, we get this data from Title 17 reporting requirements. So laboratories are required to report all positives and negative lab results for COVID-19, RSV, and influenza. And this is for facilities that are certified under a CLIA. And then those that are testing with a CLIA waiver are not required to report these results. We also get information for provider reporting. These aren't for every result, but for COVID-19, hospitalizations and deaths are required to be reported by providers. For flu, deaths in cases less than 18 years of age in any novel strain, and then RSV deaths in cases less than 5 years of age. All these data are compiled into various data products that you can view and that are put out mostly on a weekly basis. So CDPH's weekly respiratory viruses report is a great source for statewide data, which tends to follow in all the regions pretty closely. They show us the regional influenza activity levels, and then the testing positivity for influenza and RSV from those sentinel labs. They have some syndromic surveillance data in there as well, that Kaiser admission data I talked about, and then RSV and influenza deaths, including age distributions. And those can be found on the Respiratory Virus Report website on CDPH, which is listed right there. And these are some images that you can see that they have. So the one in the top right up there is our regional influenza activity levels. Those are based on testing positivity. When these were taken, it was in the low level, which is a little bit over 5%, but less than 10%. And as the testing positivity goes up, each of those regions will change. And then in the bottom left over there are a breakdown of influenza tests by type. So they break down both A and B. The center is an example of their death reporting by age. And then last on the bottom right over there is the syndromic surveillance. So those are all available on one report. CDPH also has modeling available, so they take the data that they're getting from all these sources and try to predict what we are going to see. Right now, it's predicting hospitalizations for influenza. COVID-19, they used to have it up for hospitalizations as well, but due to changes in reporting requirements at the federal level, that is no longer available. However, the federal government is requiring that hospitals report these data through NHSN again, starting next month. So once they have that data stream available, you'll be able to see those hospitalization projections for COVID again as well. Also available for COVID are estimates for the R effective and the variants. So the R effective gives us an idea of what COVID is doing in the community, if it's spreading or if it's on the decline. And that is available for the state and for the county there. And then lastly, the variants, which are pictured on that little top graph right there, they will show us regionally variants that are circulating and their projected increases based on the variant type. Wastewater data is also available. So there are 2 sites within Kern County, both located in Bakersfield, where they take samples of the wastewater and test them for the presence of COVID. That information is available on a dashboard, and you can see on the bottom graph, the bottom left down there, that it kind of tends to follow the same graph we'll see with COVID as we get from testing results. So it's a good source of letting us know what's coming up, even if we're not detecting things through testing. Lastly, local available data that we have a respiratory illness dashboard that's going to be coming up that will show us local testing positivity for COVID-19, influenza, and RSV. This will be updated daily, and at the end of my presentation, I'll kind of walk you through what it looks like. Historical data will also be available on there, and we'll go through that on the presentation. I'm going to talk about some of the trends that we see with these illnesses. COVID-19 is a little different than we see with flu and influenza, that we have a 2-peak season with a peak in the summertime and a much larger peak in the wintertime. So on the graph here, this is our COVID test, positive tests through the start of the pandemic. And as you can see, we have those 2 peaks every year. So 21, 22 is the year that we had the biggest one there. We had a rise in the summertime, followed by a much larger one in the wintertime. And that tends to be what we see every season. One thing that you notice is in 22, 23, it looks like that trend was reversed. And that's just an artifact of testing. Testing went down, so we didn't have as many results later on. And you can see for 23, 24, we still see that trend where the results coming through are less. Another interesting thing with COVID data is we have vaccination coverage data available for COVID. and locally only 5.4% of eligible residents are up to date on their COVID vaccinations. Flu data is primarily available at the state level. Regional data on flu reports is the closest we have to local data, and we usually see it move from our minimal activity level at the end of October and increase through January, dropping off towards the end of March. Local testing data is now more available with reporting requirements, but historical data will be limited, so that local dashboard will have testing positivity data for local areas, but we won't be able to really go back in time with it. And the same is true for RSV. So locally, RSV data only went into effect in 2023. So it'll be more available for us, but we won't be able to kind of look back at the past. However, we can see regional and local data follows a very, or regional and state data rather, follows a very similar pattern to influenza, where it tends to rise in the early fall and then peaks there in midwinter. So some risk factors for severe disease for all three of these are older age, 65 and older for influenza and COVID, 75 and older for RSV. Those that are less than 2 years of age for influenza and RSV, people with chronic organ diseases, obesity, smokers and former smokers, pregnant people, those with a weakened immune systems, and those with asthma. Our populations here in Kern County have many of these risk factors. This is a very text-heavy slide. We're going to go to some graphs. But here you can see that 43% of our population is obese, 26% smoke some days, and 14% have been diagnosed with diabetes. So here's a breakdown of these in a graphic format. So at risk due to age is 17.2%, with 4.1% of those less than 2 years of age. 7.8% of those are 65 to 74, and 5.3 of that is the 75 plus. 43% of our population is at risk due to obesity, 10.1% at risk due to diabetes, 26.3% due to either current smoking or daily smoker or past smoker. Translated into population numbers, that's 154,800 for age, 392,400 for obesity, about 91,000 for diabetes, and 236,700 people for smoking. And last, I'm just going to go through a quick demo of our new dashboard. So this will be available starting soon next to our COVID dashboard. And then as we phase out our COVID dashboard, we'll have a combined respiratory virus page where this will be available directly on it. Like I said earlier, it'll be updated weekly with testing positivity for both COVID, influenza, and RSV. Each graph represents one of those diseases. So this first one up here on the top is COVID. Next is influenza. And then if we scroll down, you'll see RSV. And each of these can be operated independently. And you can see snapshots of it from 4 weeks, 8 weeks, or 16 weeks out. And the charts depict our daily test count, which is the blue columns, and then the daily testing, or the 7-day average testing positivity, which is the green line there. Again, you can do that for all three of these. Lastly, what will be available on here are historic data. So for COVID, we have really good data. Since the start of the pandemic, all tests have been required to be reported. So we have pretty complete data there for all the years of the pandemic and beyond. And as you can see on this chart, and you can see that nice seasonality there. You can view this two different ways. You can view it in a calendar view, which is the traditional start with January at the end, or you can switch it to a seasonal view, which lets you view it in a format that follows the respiratory virus season. You can also select different years on here if you wanted to and just compare certain ones, or you can add them all on there however you like. You can also view flu, but for flu we only have 2023 due to new data reporting requirements. The previous data is not great for positivity, as there wasn't a requirement to report all negative labs, so the positivity is artificially inflated. RSV is not currently available on this because they only started requiring them to report those results in October of last year. So the same thing we see with that, where we see a really high positivity that isn't actually indicative of what we were seeing with the data. Questions? All right, well, thank you very much. Appreciate it.
Thank you, Paul. All right. Our next guest is Kelly Young, Immunization Avenger. As a nurse consultant with the California Department of Public Health, Kelly has taken on the epic mission of keeping California safe and healthy. Since January of 2022, she's been on the front lines as a COVID-19 vaccination nurse consultant, ensuring that every superhero and California resident gets their booster powers. With 22 years of nursing experience under her belt, 17 of which are in the high-stakes world of emergency and trauma care, Kelly is no stranger to high-pressure situations. Now she's using her super skills to provide clinical nursing consultations for the California Vaccines for Children program, helping to educate, the next generation on the power of vaccines. But wait, there's more. Kelly is also the creator of vaccine education materials, crafting resources that empower families and communities to make informed choices. With her incredible expertise and passion for public health, Kelly is not just a nurse. She's a true health superhero dedicated to saving the day, one vaccine at a time. Please join me in warmly welcoming Kelly Young.
Thank you. Next superpower is standing up in front of a bunch of people and talking. So, got some data regarding respiratory viruses within your county. And one of the best ways that we can sort of preempt a lot of the deaths and the disease burden that come from those respiratory illnesses is making sure that our patients, our community members, are aware of the vaccinations that are available to them for prevention of those winter respiratory viruses. So we're going to go over a few things: COVID-19 vaccines, current recommendations for COVID-19 vaccines, influenza vaccine, respiratory syncytial virus or RSV vaccines, and then we'll talk about how to approach the subject of talking with our patients about vaccines. So layering our preventative measures really goes a long way to prevent illness. So it's not just a singular approach to preventing illness. We want to talk to our patients and make sure that they're aware of things like hand washing, wearing a mask if they're ill, or going into large public gatherings, closed spaces, indoor public places where they're mixing with other people outside of their home. Testing. If you're symptomatic, we want them to go get tested so they know whether or not they have something that is going to spread to other people. And treatment. If they're symptomatic, they need treatment. We want to make sure that they are aware of the treatment resources that are available to them. And again, staying up to date on those vaccines is incredibly important. So the upcoming fall respiratory virus season for our children, the disease burden, we often think, oh, kids are very resilient, they bounce back. But what we can see with COVID-19, with flu, with RSV, kids bear very heavy disease burden when it comes to these viruses. It caused 22,000, COVID-19, 22,000 illnesses, hospitalizations from that. And there were 800 deaths. So we don't often hear about the deaths that kids are succumbing to this disease. We just hear, oh, kids don't get as sick as adults in the media. And that translates to our patients where they hear, oh, kids don't get as sick, so they don't really need a vaccine. But the numbers don't lie. They paint a pretty stark picture of how this impacts children. Flu, 20,000 hospitalizations. So these are little kids. Everybody thinks flu is harmless. Little kids, harmless flu, they'll be fine. But 20,000 kids last year ended up in the hospital because of flu. 300 deaths related to that. And then RSV, very closely behind those. Lots of hospitalizations, thousands of kids. This is a disease that very much impacts kids, especially in that under 5-year-old age group. very much impacts them. And for adults, these respiratory viruses really are no different. Adults also carry a very heavy disease burden when we're talking about respiratory virus season. COVID, flu diseases peak typically in the fall and winter. Right when we're going back into our homes, the weather starts to cool off and we're in enclosed spaces with a lot more people. Adults 65 and older had the highest rates of hospitalization related to COVID, flu, and RSV. And adults 65 and older had the highest percentage of deaths related to these viruses. So at a glance, what are we looking at? Influenza, RSV, COVID-19. These are it's not just a cold. These viruses cause a lot of illnesses, a lot of hospitalizations, and deaths, especially in the wintertime. And who is most effective? You can see the chart here. This one goes over annual deaths related to our respiratory viruses. So it's huge amounts of impact on our healthcare system. So these are people that are occupying beds. When we have other people coming in, there's a bed that's taken away each time for somebody else who might need it. And we're kind of in that prime window for vaccination. October is the time to start getting these vaccines to our patients ahead of the peak of that season when there's less risk of exposure, when we can get them that preventative measure before they get sick. So COVID-19 still causes lots of deaths, still causes lots of hospitalizations and illnesses. And you can see here, in comparison, COVID in that orange section beats out all the other respiratory viruses by a long shot. Routine scheduling for our 6-month to 4-year age group. This age group still requires a primary series, if you will. If you're giving Moderna in your offices, that is a 2-dose series for our 6-month to 4-year-olds. For Pfizer, it's a 3-dose series. And then if they've had prior doses, they just need the updated, most current vaccine. For our infants and toddlers and our preschoolers, all of the doses should be from the same manufacturer. However, there is some flexibility about the interchangeability of these vaccines with the children who are presenting to your office and maybe they got Pfizer at their previous visit. They would need to complete a 3-dose series regardless. So if you only have Pfizer and they had received Moderna, they can receive the Pfizer. If under that circumstance, they wouldn't receive a vaccine at all. So there is some interchangeability available for that age group, but they should be getting the same manufacturer for all of their series. Everybody else, 5 years and older, at least one of the updated doses for the 24-25 season, at least 2 months from their previous dose. So if it's been 2 months, they can have the 24-25 version of the COVID vaccine. For patients who have, this question comes up quite frequently, but I just had COVID, do I need to get a vaccine? They still should get a vaccine. There is some leeway, maybe consider delaying 3 months because there is some protective immunity through that 3-month period that if they wait 3 months to get a vaccine, the likelihood in that 3-month period that they would get reinfected is very small, so they could wait to extend their immunity for a little bit longer. For children who are transitioning from a younger age group to an older age group, so you have a 11-year-old who is now turned 12, the CDC states that those children should receive the vaccine dose that is appropriate for the age they are on the day they receive the vaccine. So they turned 12 yesterday, they're gonna get the vaccine, or they were 11 yesterday, they're 12 today, they're gonna get the dose for the 12-year-old. For influenza, we're all pretty well acquainted with influenza, it makes everybody feel pretty miserable. But disease burden, influenza causes a lot of illness. 35 to 65 million people were infected with flu and got ill from the flu last year. 16 to 30 million of those had medical visits, and 390,000 to 830,000 hospitalizations because of flu. And deaths, pretty high, 25 to 72,000, so pretty significant disease burden for something that most people look at and go, oh, it's just the flu. So the recommendations for flu vaccine from the CDC came out in August. And what they stated is everybody 6 months of age and older should receive an annual routine influenza vaccine. This year's version is a trivalent formula, so that's new this year. Last year's was a quadrivalent formula. This year is a trivalent. They have removed the influenza B Yamagata virus because they haven't detected that in quite a few years, since March of 2020. So they removed that strain from the flu vaccine, so now we're at a trivalent formulation. Our flu vaccines now contain an H1N1 influenza A, an H3N2 influenza A, and a B Victoria strain in that vaccine composition. The best time to vaccinate for influenza is starting in September. So when those vaccines first come out, we want to start telling our patients it's time to get that vaccine, time to get updated. Want to get ahead of exposure, right? So virus levels right now are fairly low across the board, but we want to get them before those virus levels climb and they're higher risk for exposure. 6-month-olds to 8-year-olds. So if they did not receive 2 doses of flu vaccine before July of 2024, they need to get 2 doses of flu vaccine and space those 4 weeks apart. So if they are 6 months to 8 years old, they had to have received 2 doses before July of 2024, otherwise they need to get 2 doses. If they received 2 doses prior to July of 2024, they would only need 1 of the updated vaccine. For 65 and older, they are preferentially recommended to receive any of the enhanced flu options. So the enhanced flu options are the ones that you see here, the adjuvanted. It contains an MF59 adjuvant. This is your fluad. Our high-dose flu, so this is the 4 times, like our double dose of flu basically, our flu zone vaccine, and our recombinant vaccine. So these are all our enhanced options for flu vaccines. 65 and older should receive 1 of those enhanced options. For solid organ transplants, recipients are 18 to 64-year-olds, any age-appropriate, not live, inactivated, so our inactivated non-live vaccines, including any of the enhanced options. So if you're only stocking a non-enhanced option, if you have a solid organ transplant patient, they can receive that one. If the only thing that you currently stock in your office is the enhanced option, they may receive either one of those, slightly different than last year's. We just want to make sure that they get some sort of protection, so that's why the expansion of what type of vaccine they can receive. And this is just kind of a depiction of the decision tree for our 6-month to 8-year-olds who haven't received that 2-dose prior to July. So if they have, it gives you a decision tree of which direction, how many they should receive this season. RSV is pretty new for everybody as far as the vaccines are concerned. RSV causes a lot of hospitalizations, especially in our 0 to 4-year-olds and our older than 65 age groups. So lots of hospitalization. They're usually the ones that are going to get the most ill from RSV. Our weekly hospitalization rates at its peak in 23-24, RSV accounted for nearly 80% of all infant respiratory hospitalizations. So kiddo that's going to get hospitalized with a respiratory virus or respiratory illness, 80% of that was going to be caused by RSV. Prior to last year, we had 0 options for preventing, no, I won't say 0. We had very, very limited options for preventing RSV in our infants and toddlers. Now we have several options. We have mom's maternal RSV immunization, and then we have Beyfortus or nirsevimab for our infants under the age of 8 months. Moms should receive Pfizer's Abrysvo at 32 to 36 weeks pregnant starting September 1st. That one will be given mom as long as they fall into that age group or that gestational age group through January 31st. We expect that there will be long-term transmission of antibodies to the baby to cover them through the entirety of that RSV season. For infants, if they are born during or coming into their first RSV season, starting in October, we want to make sure that they get a dose of nirsevimab if mom has not been vaccinated. The vaccination window for nirsevimab is October 1st through March 31st. Maternal RSV vaccination and receipt of nirsevimab, nearly half of infants did not get any sort of benefit from either maternal or nirsevimab administration. So almost half received no coverage from either one of these options. And preliminary data that we have received from the CDC shows that nirsevimab is 91 to 98% effective at keeping babies out of the hospital from RSV infection. So the guidance, I know there's a lot of guidance for this one, and it's very difficult sometimes to understand. For that baby going into the first RSV season, under 8 months old, it is a weight-based dose. So based on their weight, if they are under 5 kilograms or under, they'll get a 50 milligram dose of the Beyfortus. If they are over 5 kilograms, they get the 100 milligram dose. Before the start of RSV season, so again, starting October 1st, we want to start getting those babies into our offices to get nirsevimab before the RSV season really kicks into high gear. If mom has not received Abrysvo, then baby still qualifies. Do keep in mind for Abrysvo, and we'll go into this in a future slide, Abrysvo is a one-time dose for one pregnancy. So if mom gets pregnant again very shortly after, they would not get Abrysvo again. For high-risk 8 to 19-month-olds, those children going into their second RSV season would receive a 200 milligram dose. This is not a weight-based dose. It is one standard 200 milligram dose at the start of RSV season if they are at high risk for severe RSV disease. So protection from nirsevimab is expected to last at least 5 months. So if you have a baby that's getting their first dose for that very first RSV season, we expect that it will carry them through the entirety of RSV season. For pregnant people who receive that RSV vaccine during a pregnancy, a previous pregnancy, if you have a mom who got the Abrysvo vaccine last October for a pregnancy at that time, if she gets pregnant again this October, she would not qualify to get another Abrysvo. So it's a singular dose for now. There are ongoing studies to determine whether that needs to change in the future, but we don't have that data back yet to change that recommendation. So in those subsequent pregnancies, those infants would need to receive nirsevimab for RSV season. For older adults, ACIP recommends the following older adults to receive a singular lifetime dose of nirsevimab. These are 75 years of age and older, need a singular one-time dose. The age last year was much lower. They had them at 65 with provider recommendation or shared clinical decision making. This year, 75, anybody without regard to shared clinical decision making, they receive a singular lifetime dose. If they got one last year, they do not get one this year. Patients who are 60 to 74, if they are at risk of severe RSV disease, increased risk, and we'll go over that in the next slide of which patients fall into that category, they would also qualify for a dose of any of the RSV products for adults. RSV vaccine can be given year-round, but to get the best benefit of that administration, you're going to be giving that in the early fall to maximize the coverage through the RSV season. So chronic medical conditions that fall into the high-risk category, those are patients with chronic lung disease, so things like COPD, emphysema, cystic fibrosis, interstitial lung disease, so those kind of chronic lung conditions, cardiovascular disease if they have a history of CHF, or congenital heart abnormalities. Moderate to severe immune compromise, so patients who are taking immunosuppressants, HIV patients would qualify for the high-risk category. Neurological or neuromuscular diseases that impair a patient's ability to clear their airway also would be in that high-risk category. Chronic kidney disease, diabetes that involves some sort of end organ damage also would need to receive any of the RSV vaccines. Patients who are frail, so these are our patients who maybe are undernourished or malnourished, they don't move much, maybe bed-bound patients. Those frail patients also need to receive an RSV vaccine, as well as patients who reside in long-term care facilities or our SNF facilities. They would need to get an RSV vaccine. For our adults, Pfizer, GSK, and Moderna vaccines, there is no preference for which one is used. It's whatever you have. We want to get those qualifying patients any of those vaccines. So Pfizer for older adults, and for our pregnant women. Abrysvo is the only RSV vaccine for pregnant women. GSK's product, which is the Arexvy, this is only for our older adults. One thing to be aware of is FDA has approved it for use in 50 to 59-year-olds, but it's not currently recommended by the CDC. And then we have Moderna's Mrezvia. This is an mRNA RSV vaccine. Co-administration for any of the vaccines. You can administer COVID, flu, RSV all at the same time. So if you aren't sure a patient's going to return to get all three, it is okay to give all three of those on the same visit if there is no guarantee that they're going to come back and get that follow-up vaccine. You do want to make sure you warn them that they may potentially have a little bit more side effects, so a little bit more of the body aches. These typically are mild to moderate and usually clear up in a couple of days, but it's still okay to give them, so we do want to make sure that they're aware of that. For patients at high risk for becoming seriously ill, you want to make sure that they are aware that co-administration, if you have to come back, are you really going to come back? We want to make sure that they're aware of the risks and benefits of delaying getting any one of those vaccines. And then no minimum, if they do decide they want to get one at a time, there is no minimum time frame. So if they want to schedule one a week, we just want to make sure that we warn them to be careful not to get exposed to anything before they get their vaccine. So how do we talk to our families? This is a big topic. It's sometimes because patients can be like, well, I don't want it, and it's easy to kind of just step away and take them at their word and not really discuss the reasons behind. But we really want to make sure that we're sitting down and talking with our patients about getting vaccinated and why they don't want to get vaccinated so that we can make sure that they're covered. So one of the biggest things that as providers that we can do is really make a strong vaccine recommendation. They did a study earlier this year in April and March of pregnant women about RSV vaccination. And the pregnant women who received a strong provider vaccination recommendation were one of the 2,000, little over 2,000 people that were surveyed. 57% of those who received that strong vaccine recommendation got vaccinated. So having a provider bring up the topic of vaccines really influences acceptance of that vaccine. So when you have a patient in your office, hey, I see that you are due for your COVID, your flu vaccine, your RSV vaccine. These will protect you from winter respiratory viruses. Let's get them ready for you. And you will always get that patient that will say, I don't think so. So you want to talk to them about the whys, and there's a very sort of directed approach. It's called motivational interviewing. Find out why. What's the reasoning behind not wanting to get vaccine? Is it a time thing? Is it, they have questions. They're concerned about side effects. So 4 steps you want to take. Be empathetic. Understand that they may not have the same level of knowledge social media, patients read into a lot of the social media stuff. A lot of them get their news from there, so they're really sort of in tune to like rumor mill type of things. Find out why. What are they hearing? What's driving their decision not to get vaccinated? And be empathetic to that. It's very easy for us to kind of stand up and go, you know what? Just do it because I say so, because we have the background knowledge of it. So try to understand where they're coming from. Ask permission to share your experiences, what you believe to be the reasons why it's good for them to get the vaccine. You know, if they have high-risk conditions, apply the motivational, we'll go over that in just a couple of slides, apply motivational interviewing techniques. And then respond to any questions. You'll always get that patient that asks 800 questions, but you know, if it drives them to actually protecting themselves, sometimes the questions, it helps them to make that decision a little easier for themselves. Be curious about the reasons why. Again, maybe they had a neighbor that told them that the vaccine wasn't any good or what have you. So we want to find out the whys of how they're making this decision. Don't argue with them, don't debate. It usually devolves into a contest over who knows more about what. Just be sensitive to where they're coming from and try to figure out what's driving their decision. Ask permission to share why you think it's important. Can I share with you why I think it's important that you get these vaccines and the reasons that I think it's important that you do it today? If the patient says they don't want to talk about vaccines, leave the door open for a continued conversation at future visits. Okay, we'll table this for this visit, but when you come back, I would like to discuss these things with you further. And then the interviewing techniques, there's a mnemonic. Fortunately, somebody else besides me came up with this because I'm terrible at them. But this is ORS. O for opening the conversation. Use open-ended questions. If you leave it at yes or no, you're going to get yes or no answers. So leave it at open-ended. Try to get as much information from them as possible. Affirm positive behaviors. Things like, that's great, you got your flu vaccine. Now let's talk about getting a COVID vaccine or some of your other annual vaccines that you might need. And reflect what you hear. So it sounds like you have concerns. How can I help you navigate those concerns? And summarize your conversation so that you can repeat back to them what you're hearing from them so that they can say, no, that's not exactly what I said, and you can correct course on that conversation with them. One of the greatest questions that I used in a vaccine clinic is, on a scale of 1 to 10, how likely are you to get, it was a flu vaccine, but in this case, a COVID vaccine? And then ask them, why did you pick that number versus a higher number or a lower number? So that you can figure out, like, how far over the fence do I have to keep kind of, you know, what other things can I provide to them to get them to the 10 to agree to getting that vaccine? What would it take to get you to that higher number? If they're asking for information, if they're asking for time to contemplate, that gives you some frame of reference for where the patient's coming from. The goal is ultimately to really get them to agree to get a vaccine. Respond to questions. If the patient asks questions about vaccine safety, vaccine risks, their health, how those vaccines impact their health, and it's maybe something you're not so comfortable exploring with them, or maybe you're not well versed in those things, teach the patient how to find appropriate sources for those information and how to determine where that source is coming from and if it's a reliable source. You know, there's lots of places to get information and patients don't always know the best place to go get that information. If you don't know the answer, reach out. Reach out to your local health department, reach out to the immunization branch. We have plenty of resources that will help you provide that information to your patients. And I have a list of resources here that will help provide you information about talking to patients about vaccine. Public Health Communication Collaborative has an online series on how to communicate vaccines to your patients and gives you an opportunity to discuss a lot of those things and practice those techniques with those training modules. patient-parent resources here at the bottom as well. So if there are questions, resources that you can share with your patients that are from good, reliable sources. And then any questions? Yes?
Now that we've had some time to research like the COVID vaccine, what are the most reported negative side effects? And is that affecting what populations are kind of urging to get the vaccine?
So side effects for this year's COVID vaccine really track kind of along the same lines as previous. A lot of the body aches, headache, fever, typically 1 to 2 days. I recently got my own COVID vaccine on the same day that I got the flu. And the next day I felt pretty rotten, but then I woke up Sunday morning and it was fine. And there wasn't any sort of ill side effect after that. My little one got both of his on the same day and kind of right along with those same. And I don't know that the side effects are what's driving people for kind of being hesitant of accepting. It doesn't seem that that's, at least anecdotally, what we're hearing.
I'm kind of talking about like the hearing loss, like somebody or somebody or somebody.
Yeah.
Pregnancy, stuff like that. Do we have kind of some of the research?
I would have to look into the data for that. VAERS, you can actually go into the VAERS website to see each vaccine. You can look up specific vaccine, but I would have to gather that data, and I don't have that readily available. But I don't know if there's been a study if those side effects are what's driving people away from the vaccine.
Okay.
Other questions? Okay.
Thank you, Kelly. All right. It is with great pleasure that I get to introduce Dr. Christopher Lyon, the ultimate health defender and emergency medicine maverick. As the Kern County Public Health Officer and EMS Medical Director, he is at the helm of public safety, ensuring that our community is ready for anything that comes our way. With board certifications in both emergency medicine and EMS medicine, Dr. Lyon is armed with knowledge and experience, making him a true force for good in Kern County. Whether he's saving lives in our local emergency rooms or declaring public health emergencies, this superhero is dedicated to keeping Kern County safe and sound. Dr. Lyon also trades his white coat for a tactical vest as a reserve deputy and medical team leader for a law enforcement SWAT team. He combines his medical expertise with law enforcement training, ready to spring into action and providing life-saving care whenever duty calls. Talk about versatility. Please join me in warmly welcoming Dr. Lyon.
Well, thank you, Bren. Thank you, everybody, for coming tonight. I appreciate you being here. So tonight I'm talking about preventing hospitalization and outpatient management. This is geared towards information for you, but also information to educate your patients. Some of this may seem obvious, but sometimes we need to try to model and educate our patients about what may be second nature for us, but is not necessarily at the forefront of our patients' minds. So the CDC has 5 core strategies for winter respiratory viruses: staying up to date on vaccinations, good hand hygiene, making sure you're having cleaner air in your house or wherever you are, staying home when you're sick, and seeking health care when you're higher risk. So while some of this is going to be repetitive, sometimes repetition helps things sink in a little bit, I guess. But immunizations are probably the most important thing for us to try to communicate to our patients. Again, COVID-19 and flu vaccinations for everyone 6 months and older, RSV immunizations to protect our infants and elderly, So I'm going to go through each one individually. So for influenza, there's actually a pretty impressive NNT for the influenza vaccine, a number needed to treat to prevent influenza of 71 for all comers, but 29 for elderly and 5 for children. And really, what we're trying to do is attenuate the virus influence. So taking it from a potentially severe illness and making it much more mild, or preventing infection altogether. Again, we want to try to have patients start getting their immunizations in around September, and preferably before October or November, so that they're fully protected when peak of influenza season is. Adults 65 and older should be getting their high-dose adjuvant or recombinant vaccinations, and there's good data to support that this significantly improves their outcomes. Pregnant women should be vaccinated as they are high risk. And ACIP has come out with statements saying that even if you have an egg allergy, you can receive any of the vaccinations. One thing to keep in mind is that for immunocompromised or pregnant patients, again, you should not be giving the live attenuated vaccine. You should also avoid co-administering antivirals, as this can decrease the vaccination effectiveness. RSV is not just another cold. It can produce significant morbidity and mortality for both adults, older adults, and young children. It's the leading cause of infant hospitalization in the US. For children, we should be vaccinating all young infants against severe RSV through one of the following programs, which Kelly reviewed earlier. Interesting, there is a really interesting study that showed that the RSV immunization decreased hospitalization from bronchiolitis-associated admissions by 60%, as well as decreased overall ED patients coming to the ED for bronchiolitis by over 20%. And again, adults, all adults, 75 and older should be getting vaccinated if they haven't previously been vaccinated, or 60 to 74 if they have high-risk medical conditions and history. I'm not going to go through every risk factor. Kelly went through many of them, but these are your common chronic medical conditions that you see on a daily basis. For COVID, again, vaccinations. Everyone 6 months and older should be getting the current COVID vaccine. It decreases illness, severity, hospitalization, and death. So we've moved past the vaccinations. I tried to go through that pretty quickly since we've already had a great overview of that. Again, things that are second nature to us, but are important to talk to your patients about. Hand washing, trying to model this and educate our patients about good hand washing techniques. It can reduce respiratory illness by 16 to 21%. Hand sanitizer, which should be at least 60% alcohol, and cleaning and disinfecting high-touch surfaces. And this is also important to talk to patients about, to use the manufacturer's instructions. It's not just a wipe off and it's done. It has to sit and have a particular time on the surface to appropriately disinfect. Covering coughs and sneezes and discarding tissues, and washing hands after you do that. Obviously, a lot of this seems second nature and obvious to us that deal with it daily, but it's important to talk to your patients about it. Clean air. So improving air circulation, setting the HVAC fan to on instead of automatic when visitors are present, and changing filters every 3 months or as per recommended by the manufacturer. having a HEPA cleaner, or having gatherings outside. It is still okay to wear a mask. And this can help protect you and others. So whether you want to do this, you can do this inside, you can do this outside. This can be something your patients can do as well. Also, avoiding crowds. Other things that our patients can do: improving their overall health, having good nutrition and hydration, a healthy weight, managing stress, getting plenty of sleep, and avoiding touching their eyes, nose, and mouth to decrease transmission. What to do when you or your patients are sick. We are probably the worst about this, but stay home. You know, it's hard. I mean, working in the ER, it's hard to find coverage. And a lot of us have gone to work sick. We really probably shouldn't be doing that because we're exposing our colleagues and our patients. Distance yourself from others. Wearing a mask to try to decrease transmission, and washing and sanitizing your hands regularly. But again, this is something that we know. We don't always practice it well, but it's something that we should try to communicate to our patients. These are things that we know when we should seek emergency evaluation, but our patients don't always understand this. Just simply having a fever isn't necessarily something that you have to seek emergency care. But if you have other symptoms that are severe, then it is an indication to be evaluated. And treatment. Haven't we been through the gamut of options for treatment for COVID? Well, we're going to go through some of the recommendations as well as some of the recommendations against particular treatments. And we're going to go through both influenza and COVID. There's not much for RSV. So neuraminidase inhibitors can have some indications. However, they only reduce symptoms by about 12 hours, and there are symptoms associated with them. While they are effective and there are indications, we just need to know that there are risks with them and there's not a huge amount of time decrease. And they really need to be started within 48 hours of symptom onset. So risk factors, again, for severe flu have been covered already, so I'm not going to go through each one of these, but these are some of the ones that you would consider for individuals who you want to consider treating with antivirals. So a lot of the recommendations I'm going to review are from the IDSA, the Infectious Disease Society, about who should get what and when. So clinicians should start antiviral treatment as soon as possible, so within 48 hours of symptom onset, for adults and children with documented or suspected influenza who meet the following. So patients of any age who are hospitalized with influenza, outpatients with severe or progressive illness, outpatients who are at high risk of complications, children younger than 2, adults greater than 65, and pregnant women, and important to consider is postpartum women up to 2 weeks. You can also consider treatment who are not at high risk with documented or suspected influenza for outpatients with illness onset less than 2 days before presentation, symptomatic outpatients who are household contacts, a person who are at high risk or severely immunocompromised, or symptomatic healthcare workers who care for patients who are at high risk of developing complications from influenza. Clinicians should start antiviral treatments as soon as possible with a single type of antiviral. We should not be combining antivirals, and the dosages should be the doses recommended by the FDA and should not be higher doses unless there's some particular reason. Should treat uncomplicated influenza in otherwise healthy ambulatory patients for 5 days for oral oseltamivir or inhaled zanamivir, or single dose of IV perimivir. Clinicians can consider longer treatment for patients with documented or suspected immunocompromised conditions or patients requiring hospitalization. So chemoprophylaxis is not generally recommended for routine or widespread chemoprophylaxis outside institutional outbreaks, but can be considered depending on the situation. And again, should be done within 48 hours of exposure. Neuraminidase inhibitors are effective at preventing influenza, which is also the reason why you don't want to give them immediately after giving vaccinations. So this is in your handout, so I'm not going to go through every single one, but these are the treatment recommendations. RSV highlights the importance of immunizations. There's really no particular treatment option other than supportive care. Now for the fun ones, right? So hydroxychloroquine and azithromycin, they recommend against in all circumstances. Lopinavir and ritonavir, they recommend against. Steroids. So dexamethasone has recommendations for use. So hospitalized critically ill patients with COVID, they do recommend dexamethasone rather than no dexamethasone. Patients with severe but non-critical, they do recommend dexamethasone rather than no dexamethasone. So this is essentially patients that are requiring supplemental oxygen. Critical patients would be those that are intubated or on ECMO. So if somebody is admitted with mild to moderate COVID, but they're not requiring supplemental oxygen, they do not have hypoxemia, and they define this as 94%. So patients with a SAT of 94% or higher, they do not recommend glucocorticoids. They recommend against inhaled corticosteroids, but those who are on inhaled steroids for other indications should continue them. They do recommend remdesivir for patients that have it initiated within 7 days of symptom onset with mild to moderate COVID who have a high risk for progression. They also recommend remdesivir in patients on supplemental oxygen, but not on mechanical ventilation or ECMO. And they suggest treatment with 5 days rather than 10 days. They also recommend it in hospitalized patients with severe COVID over no antiviral treatment. So again, that's those requiring supplemental oxygen. Interestingly, they do recommend against it in those with critical illness, so those that are intubated or on ECMO. They recommend against ivermectin. Sorry, I'm going to butcher that one. Nirmatrelvir and ritonavir. They do recommend that this can be used for mild to moderate COVID at high risk for progression to severe disease. Molnupiravir is an option if there is no other choice for the patient. So if they have a contraindication, for instance, to Paxlovid, then this is an option as long as they're not pregnant and they're over 18. And it must be initiated within 5 days of symptom onset. Colchicine is not recommended. Azithromycin is not recommended. They didn't have a specific flow sheet for IDSA, but this is from the NNT.com, and there's no benefit. So the main options are remdesivir, Paxlovid, and Lagravir. We'll say that 3 times fast, right? Let's all say that? Pre-exposure prophylaxis with PEMGARDA. It's a monoclonal antibody. In the EUA authorization for pre-exposure prophylaxis in adults and adolescents who are not currently infected with COVID and have not had a recent exposure to COVID and are moderately to severely immunocompromised and are unlikely to mount an adequate response to COVID-19 vaccination. So this is a single IV infusion. It lasts for 3 months. It does not replace vaccination. So when can we return to activity and when can our patients return to activity? We must have improvement in overall symptoms and have had no fever for 24 hours without the use of fever-reducing medications. Testing. So obviously testing is important. We like testing from public health for the epidemiology, so we can have great graphs to demonstrate how much we're seeing and to communicate that to you. But it's also important for us to have the testing for treatment considerations, symptom management, and infection control. The antigen tests may produce false negatives, results early, but false positives are much less common. Co-infections and secondary infections can occur, but in many studies where people were given additional antibiotics, for instance, there was really very minimal evidence of bacterial co-infection. So in most circumstances, antibiotics are not indicated. So while we've talked a lot about COVID, influenza, RSV, we do need to remember that there are still lots and lots of other viruses that we don't have treatments for that we now have the ability to diagnose when we, for instance, we send our respiratory biofire, but these also can cause severe morbidity and mortality and highlight the need to continue with our non-pharmaceutical interventions. Also remembering measles and rubella can cause a cough, but usually will have a rash associated with the fever as well. Other reportable non-viral respiratory infections are still occurring as well. There's lots of cocci that we're seeing continually here, cocci meningitis, really have a high suspicion for valley fever. We're seeing more and more pertussis throughout our country. There is still TB here in Kern County as well as throughout the US, and then many other reportable non-viral respiratory infections. So again, immunizations, hygiene, clean air, treatment, and staying home. Healthcare providers are the most trusted source of health information for their patients. Immunizations and early clinical intervention can protect against hospitalization, long-term health impacts, and death. All patients should receive education on prevention and mitigation measures and consider providing additional education and stronger recommendations for patients at high risk. Thank you for all that you do every day for our patients and taking care of yourselves.
Thank you, Dr. Lyon. All right, prepare to be inspired by our last esteemed guest tonight, the incredible Kimberly Hernandez, the Division Director of Health Services at Kern County Public Health. With over 15 years of experience under her belt, she's on a heroic mission to elevate community health and empower residents to thrive. Kim oversees a powerful array of vital programs tackling challenges from maternal, child, and adolescent health to the fierce battles against communicable and chronic diseases and everything in between. She's a true champion, ensuring that no health issue gets left behind. Armed with a Bachelor of Science in Psychobiology from UCLA and a Master of Public Health and Biostatistics from Drexel University, Kim blends her formidable expertise with an unwavering passion for service. Kim Hernandez is not just a leader, she's our dedicated health services superhero, working tirelessly every day to secure a healthier tomorrow for everyone in Kern County. Please join me in welcoming Kim Hernandez.
Thank you, Bryn. Good evening, everybody. Thanks for hanging in there with us. You guys might think you're getting out of here early, but I like to talk. So they're laughing because they know. We added this as sort of a late breaker. This wasn't originally on our agenda when we first started talking about winter respiratory illnesses, but we thought it was really important to talk about highly pathogenic avian influenza, H5N1, because this is going on in California right now. So some H1N1 101, just some background. The history of it is, it was actually first identified in 1997, so it's been around for a little while. We see periodic outbreaks, mostly in East Asian countries as well as Egypt, so it pops up every now and then. This is the first time it was detected in the US was back in 2022, and so we've been following it since then. Some things to know about transmission. Obviously, we call it avian influenza because it is primarily transmitted among birds. And so we do have transmission from birds to humans. We've also moved into transmission from birds to other animals, which then can expose humans as well. There has been limited non-sustained transmission between people historically. There hasn't been any identified so far in the US, but there have been a couple of cases where very close contacts who didn't have known exposures to animals have come down with H5N1. The reason we call it highly pathogenic avian influenza is because it is often very deadly in birds. That does not reflect how pathogenic or how virulent it is in people. So some people get this very confused. They hear us talk about highly pathogenic avian influenza and they're very worried that this is going to be very deadly to people. But it's named that way because it is very deadly to birds, unfortunately. We have seen some severe illness in dairy cattle, which is the animals we're looking at most often right now, but most of those cattle do recover. And so this is something where you have sick cows and then they need to be nursed back to health, which is where some of our human exposures come from. In people, so far, we're going to keep our fingers crossed, it has been very mild illness. There have been no hospitalizations reported to date in the US, and so right now, as far as we know, H5N1 transmitting in the US has been mild. So some information about our current outbreak. Wild birds, so this is where it started. This is actually where we started seeing H5N1 in wild waterfowl, and we could actually see it transmitting through the migration lines of the different birds. And so there have been wild birds detected in 51 jurisdictions across the United States, so every state. And then there have been 12 wild birds detected here in Kern County. But our last detection in Kern County in a wild bird was in December of 2023. So we haven't seen any, or at least identified any here. And this is generally with wild birds. People report wild birds. They can be tested for things including H5N1. In poultry, so this has been a big one across the US. All 48 continental states have identified H5N1 in poultry. So if you guys remember, we had a period of time where it was difficult to find turkey in the supermarket and things like that because there was unfortunately a lot of H5N1 transmitting in poultry flocks. This does include really large commercial flocks as well as backyard flocks. So if you know somebody who keeps backyard chickens, backyard ducks, things like that, this is also a risk to people who have small organizations or small institutions of poultry. The last commercial flock in California, in the last 30 days, there's only been one commercial flock identified in California, so there hasn't been a ton of transmission in poultry in California over the last couple of months. In dairy herds, this is what we're hearing about a lot right now, and this is mainly because we as people tend to have more exposure to dairy cattle than we do as people who are working with poultry. There's a lot more close contact with dairy cattle. There's been more than 300 herds identified throughout the US. 14 different states have identified herds with H5N1, and there are ongoing new detections in the state of California. And so the first one in California was identified at the very end of August, and since then we are continuing to have herds identified. Many of the ones where they were identified, at the end of August, those cows are getting better, and they are no longer detecting it in that dairy farm, but new farms are still popping up. So this is sort of where we're seeing a lot of talk about what's going on. This is also where a lot of our infections in California are coming from. An important piece to know is that H5N1 can also be found in other mammals. There's been more than 300 different mammals tested throughout the United States. These are really kind of sporadic. It's generally a wild animal that is seen, that is ill, that they're just trying to figure out what's wrong with it, and then we find out that it was infected with H5N1. It's typically carnivores, and so carnivorous animals, we think, from feeding on poultry that have been ill. So in California, we've identified fishers, bobcats, mountain lions, raccoons, and skunks. And the last mammal detected in California was back in April. So it's been a while. We haven't seen as much in those wild populations. And then, of course, the reason we're here is to talk about people. And so as of this morning, there have been 27 humans diagnosed with H5N1. This year in 2024, we have had people diagnosed in 5 states. California is leading that charge, where we've had 13 cases, and we have had 1 confirmed case here in a Kern County resident. So what do we need to know about all of this? So this is really important about assessing patients if they show up to your healthcare facility. The very first thing is, of course, you have to think about and consider the fact that it could be H5N1 in a patient that has exposure to infected animals and compatible symptoms. This is not something we're just going to try to test everybody who walks through the door, but if we have suspicions, if you know that they work with dairy cattle, if you know they work with poultry or wild birds, this might be something to consider if they're having symptoms that are compatible with H5N1. And then obviously, if you are suspicious about H5N1, it is really important to isolate that patient and implement infection control measures. If you suspect H5N1, we want you to immediately call us at Public Health. Our number, as always, is 661-321-3000. If it is after hours, it is after 5 o'clock, it is a weekend, it is a holiday, and our business office isn't open, healthcare providers can always call our on-call number. That's 661-241-3255. And then if you're suspecting H5N1, we want you to collect specimens. That's going to be the first ask when you call us, is just to collect some of those specimens. It's really important to wear your PPE when you're doing this, because we do not want infections in our healthcare providers. And then, like what Dr. Lane was mentioning, consider testing for other respiratory illnesses. It's not that they couldn't have both, but you might get a quicker explanation of something that you might also be suspicious of. So think about other causes of those symptoms, even as we are testing for H5N1. And then treating patients is really important. We want to treat patients early, and so we do want to treat them once we are suspicious, because that's when it's going to have the most benefit. Okay, so what are the symptoms? The biggest one is conjunctivitis. Of the 13 cases in California, all of them have had conjunctivitis. Another big one, when we think about things like influenzas, we're thinking respiratory symptoms, any kind of uncomplicated upper respiratory infection, as well as things like the more severe symptoms of shortness of breath or difficulty breathing. Patients can have a fever, but not all of them do, so that's not the sort of driving symptom to be looking for, but they may have one, they may not. And then there's some sort of generalized muscle and body aches, headache, and just generalized fatigue that people come in. These are similar to the things we think about when people have influenza-like illness, and so those are just things to consider. But conjunctivitis has been this main trigger, particularly among people who are known to have been exposed to animals with H5N1. So with infection prevention, it's really important to isolate that patient. If you have a negative pressure room or a negative pressure area in your facility, it's really important to get them in there to help reduce the risk. But getting that patient into their own room, away from others, out of your waiting room, is going to be really important to reduce the risk of exposing other people. Wearing PPE, really, really important. That obviously gloves are very common and standard, gown, wearing a respirator, and particularly eye protection. I keep talking about conjunctivitis, and so we need to make sure that eye protection is also included. And so that's something to really consider, because that's probably the last thing we think about a lot of times when we're thinking about PPE. And then disinfection. Obviously, if you have somebody who is sick, they're in sort of your sick area of your healthcare facility, you are going to be cleaning around them. The EPA has a list of disinfectants that have been shown to be effective against avian influenza. We call this list M. You can look it up online. You can check that whatever you are using is effective for bird flu. All right, like I mentioned, call us. Please call us right away the moment you are suspicious. Our job is to help get you connected to the appropriate testing, make sure you guys have all of the resources you need to help support this patient. If you call our after hours number and you have to leave a message, you should be getting a call back from us within 15 minutes. It's not impossible that we have multiple calls going on. This number is for all things kind of public health that may happen after hours, but we will return your call. If you don't hear from us, call us again because we should be responding relatively quickly. All right, collecting specimens. So again, before you even start collecting specimens, you need to think about PPE, make sure you have it on, and again, eye protection is really important. Swabs. So with H5N1 testing, like other influenza testing, you need to use a Dacron or a synthetic swab with an aluminum or plastic shaft. This is pretty common in most of the specimen test kits you're going to get these days, but every now and then we do still find ones that have sort of a cotton tip and a wooden shaft, and those are not good for testing. Transport media. So when you take that specimen, you're going to be putting it in either viral transport media or universal transport media. That is pretty common again with respiratory specimens. And it's again important to refrigerate if your courier is not coming to get it right away or if you're going to ship it. So what specimens do you take? If they're having respiratory symptoms, obviously we're looking for a respiratory specimen. And so we're looking for an NP swab and a combined nasal and oral pharyngeal swab. If they have conjunctivitis, we also want that conjunctival swab if they're having any kind of exudate there. And in addition to that, even if their only symptom is conjunctivitis, we're also looking for that NP swab and that combined nasal and oral pharyngeal swab. Because we are trying to look from a transmissibility standpoint, like do they have it in respiratory secretions? We have found that we have patients where we do find it in their conjunctival swab, but we don't find it in their respiratory tract. And so it can happen both ways, but this is important to make sure we're collecting all the sites where it may be detected. And then again, considering other testing. Obviously, if we're testing for H5N1, we should also be checking for seasonal influenza. Things to consider is COVID-19 as well, RSV, these big ones that we talk about because we know they circulate during this time of year. Other things to consider might be something like pertussis because that's also on the rise. And then really thinking about that conjunctivitis, adenovirus is one of the most common causes of conjunctivitis. And then thinking about just all the bacterial conjunctivitises that go around really all year, but just kind of considering that as a possibility. Because we all know that bacterial conjunctivitis is also very, very infectious. So with treatment, what are we looking for? It's really a standard antiviral treatment. Oseltamivir, Tamiflu is what we're going to be looking for. In adults, it's the typical 75 milligrams twice a day for 5 days. That's sort of a standard regimen for treating flu. So the same thing applies for H5N1. As you get smaller and younger, as you get smaller, you're going to have a smaller dose. And then, with our very small children, it's typically a suspension and not a pill form. But this is the typical antiviral treatment that we really encourage you. If you are suspecting H5N1, we want to start this treatment right away because we do know testing is going to take a couple of days. And as Dr. Lyon mentioned, oseltamivir is most effective when taken early in disease progression. All right. Overall risk reduction. So this is important if you have patients that might have exposures. And patients in general, we should encourage everybody to avoid contact with sick or dead animals. For some reason, people like to go up and poke at sick and dead animals, but we really want them not to touch them. And so this is just general good information to remind people. Encourage patients, if they work in a dairy farm, if they work with poultry, if they work with waterfowl, then it's important for them to reduce their risk of exposure and wear PPE. In many of these facilities, they already wear PPE from sort of a biosecurity risk because they're dealing with food-related animals, but really encouraging that. We hear from different areas that some facilities are really good at it, some are not. And so we just really encourage that if this is a risk factor for your patient, to remind them and ask them if they know, and ask them if they know why they should do this, because that really helps with compliance to help them understand. We know about PPE. We work in a world full of PPE. We're very used to it. And so not everybody is in that same world, and sometimes it's really important to have that conversation. It says, do you know why you need to do this? Why you need to, yes, wear goggles to protect your eyes, also, yes, wear a mask to protect your respiratory system, wearing gloves, in something like dairy farms, they wear sort of water-resistant aprons and things like that. That's the type of gown that they would have, and making sure they understand the rationale behind all of it so that it can be used effectively. Obviously, encouraging good hand hygiene and routine disinfection of high-touch surfaces. Like Dr. Lyon mentioned, this is something we do automatically because we're in the healthcare world, but it's not something everybody else always does. And so just reminding them during flu season for one, but also while this is going on, that it's really important to wash your hands. It's really important to both clean and disinfect. A lot of people, most lay people think of, as a disinfection as I've wiped it down. And that's not necessarily disinfection, that is cleaning. But like Dr. Lyon mentioned, looking at your manufacturer's label, seeing what that contact time is, and really taking into consideration how much solution of something it takes to actually disinfect and surface is really important, because in lay people, for the general public, we see on TV, you have your wipe and you just wipe down the table and that's considered clean. But that's not truly going to disinfect and protect them against things like this. And then, of course, encouraging everyone to get their seasonal flu shot. This is something we encourage all the time, every year, but this is especially important for people who may be exposed to H5N1. One, just because if they're someone who might be exposed or someone we have to follow up with at public health, this will reduce their risk of having symptoms where we might have to be suspicious of H5N1, right? If they don't get sick from seasonal flu, then we don't have to rule them out for H5N1 because they don't have any symptoms. This is also really important to just protect their overall good health so that they can continue working. In general, the risk to the public remains low. And so this is important because it's been on the news a lot. A lot of people are concerned. We get calls. We have the worried well. If they aren't exposed to animals, it's unlikely for them to have an exposure in the general public at this time. Like I mentioned, we haven't seen sustained person-to-person transmission. We hope we don't see that. And so if you have worried well coming into your office, asking, what do I need to do about this? One, encouraging these basic, risk reduction measures, is just a good practice, but reassuring people that if you work outside of these settings, if you're not gonna, show up on a dairy farm, if you are not dealing with poultry on a daily basis, your risk of coming in contact with an animal with H5N1 is going to be low. Okay, that's it for me. I wanted to take a moment to see if you guys had any questions, because I know H5N1 is a little bit newer than some of the other stuff we have talked about today. Yes? Oh. Go ahead, Leah.
This is more about, so we work with a lot of pregnant women, and I feel like when I go to the home visits, there's so many of them that are not being encouraged or strongly advised to, get their updates with the flu or the Tdap or, COVID. And so I have to literally give them a form with them to show their provider, I really want these. I was just wondering, how can we, get our community providers kind of more on board with that, or how can we do that? Because I'm seeing a lot of pregnant women not getting the updates.
Yeah, so the question, just so that everybody can hear it, is Leah works with a lot of pregnant women, and she has struggled in finding that a lot of her patients are not getting up to date while they're pregnant with those recommended vaccines. And so the question is really, how can we help our providers, or what can we do in our community so that more of our pregnant women can get their vaccinations? And so I really throw that to our community here of what would help. We do want to make them available. We try to provide education. Like we've mentioned today, a strong recommendation from a healthcare provider is really, really important. Having them available in a healthcare provider's office is really, really important for our pregnant people, because they're coming into your office once a month, then every 2 weeks, and then every week. And so depending on that timing, they may be here multiple times. If you do not carry vaccines at your facility and you are interested in that, we have an entire immunizations team who would love to help you in that process, because it is for a lot of patients a matter of convenience. It is for a lot of patients getting hearing from trusted sources, you should do this. A lot of pregnant women are very scared to do lots of things because they're worried about the effects on the baby. And so we really need to encourage, that there are things pregnant women can do that will help protect their baby, from, Tdap to protect them against pertussis, during flu season, getting their COVID vaccine, getting their flu vaccine, getting RSV vaccine, is going to help protect their baby, because as you've noticed with the vaccines we've talked about, between birth and 6 months, they're not eligible for these things. And so they need to be protected by people around them, but we know that maternal antibodies also transfer, and so it's really important. We want to hear information, if you guys have suggestions about ways we can inform our community, inform our providers, make it easier for our providers to have those readily available. Other options that have happened in the past is sort of that strong recommendation that may come out of your mouth. Papers help to follow up with that. That we have seen providers who actually write a prescription that says, go get this vaccine, because it's something the patient can walk away with and remember. Because if you give them that prescription and they were going to go, refill a medication, they're going to go get their prenatals, that's another physical reminder, but also it strengthens that recommendation. In the same way you write a prescription to help get them better, you can write this prescription to help keep them and their baby from getting sick. So I guess I have a question if anybody has other suggestions that we can share to kind of help make vaccinations more available and that information more readily accessible to healthcare providers. Mr. Oates has a response. I'm going to give you the mic so they can hear you.
Because I've got such a nice low voice. I talk to providers, excuse me. I talk to providers daily, and they call and they say, what can I do for this? What can I do for that? A lot of that information I have to go now back out and research. Call the provider back so I can advise him or her. The thing that I do mostly is make sure I've got that in writing so I can then send it to the provider's office. And along with that, I say, who is your office manager? And I send that information to the office manager as well. What I found, if both these people get the information, then they tend to talk about it. And that kind of cements it into that practice. And I get calls back from the providers saying, thanks, that really worked.
Thanks, Steve. Thank you, sir. Dr. Nguyen.
So thank you for presenting this important topic and educating us. So I have two questions. One question is the specimen collection. So it's very difficult to collect two different specimens, one for the in-house testing and then one for the public health. So how can we coordinate only from one single testing, and then after we finish the local testing, then can we share the remaining specimen with the public health to confirm H5N1? So that's number one question. Number two question is the H5N1 will also be picked up by the local testing, like the respiratory PCR panel that we usually test, or influenza antigen test, or influenza PCR test. It will also pick up and it will be positive, right? We just don't know that H5N1 subtype, or yes, it will already be in the existing results.
Yeah, so to answer the second question first, H5N1 testing is only able to be confirmed at CDC. And so it's not commercially available. In general, you can do influenza A testing. If that's sort of the first test to say if it's influenza A, then we can further look into the subtype to see if it's H5N1. And so those, that's preliminary testing can be done at local health departments. We send ours to the state health department, and then it does get confirmed at CDC. And so it's not something that's on a respiratory panel that can be done commercially or in a hospital at this point in time. And so that's why, you may take sort of that, we have a suspicion it might be H5N1, they have flu A, and then we can do further testing. Whether or not we can use the same specimen really depends on what happens to that specimen when it's being tested for the respiratory panel, or if you're doing flu A in-house, of whether or not there is enough residual and there hasn't been anything changed to the specimen so that it can be further tested. So we're happy to accept specimens, that you've already collected, as long as they're sort of in that, I guess, kind of pure form, if they're still in the VTM or the UTM, because then it can be tested. But sometimes depending on what instrument you use for testing in testing in those instruments, you can't use the same specimen collection swab.
So it seems like it will be a second swab if provider has a suspicion.
If a provider has a suspicion, it's probably fastest to do 2, because you can send through the regular testing system, and then you can send one to us, because like I mentioned, we send ours to the state lab, so there's at least a day of transport, and then they will be testing, and then again, if it has to go to CDC, and so it does take a couple days to confirm H5N1, which is why it's really important to start the process of isolating people as well as treating before test results come back.
I think that educating for everybody also, like if you have confirmed influenza A, but influenza A already negative, you don't really need to bother to check for H5N1.
Yes, that is true. 99% of the time. In general, because H5N1 is an influenza A, if your influenza A test is negative, then you're not going to find H5N1. Thanks, Dr. Wynn. Any other questions about H5N1 or for any of our other speakers? Nope. Awesome. Okay. So thank you guys all so very much for being with us here tonight to learn about respiratory viruses that transmit, in Kern County in the winter season. We really do appreciate all that you do. We have in your folder a post survey. You guys all came in and you took a pre-survey when you signed in, and then there's also an evaluation. So if you could please fill those out and return them in the back, we'd really, really appreciate that. Again, we appreciate all that you guys do for our community. If you have questions, all of your speakers are up here up front, and we're happy to take any of those individual questions if you have them. Thanks, everybody. Have a really good night and a safe drive home.